Even mild untreated hearing loss doubles dementia risk. Moderate loss triples the risk. Those with severe hearing impairment are 5 times more likely to develop dementia. Dr. Porteinsson recommends preventative steps such as healthy lifestyle choices, hearing aids, and taking recommended medications to improve individual prognosis. As a geriatric psychiatrist, Dr. Porteinsson has devoted his career to the care and study of individuals with memory disorders. He participates in the University of Rochester Memory Care Program. Having authored hundreds of research publications, he has served as principal investigator for numerous research grants. He is internationally recognized in clinical research and considered one of the leading experts in Alzheimer's disease and dementia. Ladies and gentlemen, it is indeed an honor to introduce Dr. Anton Porteinsson. Dr. Porteinsson,
Susan,
where are you?
I'm right here. Thank you for the kind introduction. I'm going to try to share my screen here because I have a, let's see. This should be it. Okay, I'm assuming that everyone can see the title slide here, Untreated Hearing Loss and Dementia.
Yeah, Dr. Porteinsson, this looks great. Thank you.
Awesome. Excellent. Thank you so much. This is a pleasure. I have spoken to this group a couple of times before at St. Paul's Church. And of course, the last time was well before COVID hit us. And now we have basically gotten quite sophisticated in using Zoom and other webinar methods. And I'm pretty impressed how suave you operated the business part of the meeting. Basically, as you heard, I have dedicated my career to people suffering memory loss. And as you heard from Susan, untreated hearing loss is a modifiable risk factor. And there are several modifiable risk factors. And because the elements of dementia, like Alzheimer's disease, is for many individuals unavoidable, but you may be able to delay the timing of onset. These modifiable risk factors become truly important. And they're not just for show. They actually are meaningful in terms of your ability to bend the curve and kind of push out the onset, the age of onset of the dementia or the memory disorder. And if we can push out the onset of dementia by 5 years, delay the onset 5 years, we will basically have the prevalence. What I mean by that is the number of people suffering for dementia, simply because of the fact that dementia is a late life development for the vast majority of individuals. Now, I will focus a lot on Alzheimer's disease. But Alzheimer's disease isn't the only dementia. There are, there are well over 100 causes of dementia. But Alzheimer's disease is by far the most common. It's the 800-pound gorilla in the room. And This is a condition that has been with us for ever. It is very much associated with aging. And this is one of the reasons it didn't attract a lot of attention if we go back 100 years or a couple of 100 years, because there was a relatively small group that actually got to the age where there was a significant risk factors. And those that developed dementia honestly did not survive very long. Because of the fact that you become much more vulnerable to injury, to all kinds of unfortunate events. You succumb or more likely to succumb to infections, etc. There was a smaller group of patients that had what we now refer to as early onset Alzheimer's disease. And those are actually much less common. This is a smaller percentage of people that develop Alzheimer's disease nowadays. But in going back 100 years, those individuals were basically believed to have kind of a psychiatric illness and tended to end up in asylums. And Dr. Alzheimer's was a German doctor that was actually a psychiatrist and ran an asylum. And he observed a number of young people that, by that I mean around 50, that were admitted to the asylum, but not with the typical kind of psychiatric disorders such as schizophrenia or psychosis or bipolar mania or treatment-resistant depression. As doctors were apt to do at that time, they kept very good descriptions of these patients. They couldn't necessarily do very much for them except provide maybe a safe environment, but they kept very good clinical descriptions of the presentation. And around the time that that Dr. Alzheimer's was doing this, actually the microscope had been discovered, and he would actually look at these individuals when they passed, look at their brains, and found the brain changes, the pathological changes in the brain that became basically sine qua non or characteristic of the brain pathology of Alzheimer's disease. And those are the amyloid plaques and the tau tangles, also called neurofibrillary tangles. And basically, you don't have Alzheimer's disease unless you have these amyloid plaques, which is basically a toxic protein that is processed in a flawed fashion. And neurofibrillary tangles are also actually a dysfunctional protein, a tau protein that has been hyperphosphorylated, so it loses its natural function. And when these two toxic proteins build up, they cause accelerated neuronal death. And the neuronal death leads to significant brain volume loss and loss of brain function. That is thinking, memory, language abilities, reasoning, and also your thus your ability to manage your life independently. And on this slide, you actually see how significant the neuronal losses. On the left side, you see a normal brain, which is full and plump. And on the right side, you see a an brain that has been afflicted by Alzheimer's disease, and you see the very significant volume loss and what we call atrophy. And basically, this photo is Auguste D, which who was Dr. Alzheimer's basically first patient that he kind of identified and described. And she was relatively young, around 50, when she came into the asylum with significant cognitive impairment and very disturbing behavioral disturbances, especially delusions, feeling that that basically she didn't recognize people around her and thought that her family had ill intentions towards her, and had no memory of recent events, so couldn't really be consoled. It was actually a pretty awful disease course. So, like I said before, Alzheimer's disease is the most common of the dementias. I sometimes hear from people, you know what, they come to my clinic for maybe a second opinion, and they say, my mom was seen by this other doctor, and thank God she only has dementia. She doesn't have Alzheimer's disease. And then you have to kind of explain that Alzheimer's disease is actually one of the dementias. It is the most common. About 2/3 of all dementia is caused by Alzheimer's disease. Another 10 to 15% is Alzheimer's disease changes in the brain alongside other changes. So it's really only maybe 25% of the dementias that are not Alzheimer's disease. And this can be dementia associated with Parkinson's disease. It can be dementia with Lewy bodies, frontotemporal dementia, vascular dementia after a stroke. So there are many causes of dementia, but Alzheimer's disease is by far the most common. Dementia is obviously from Latin, like much of our lingo in medicine, and means reduced mentation. And as a syndrome, it includes a progressive loss of thinking, usually short-term memory, but it's associated with loss in other areas of higher cognitive function, such as executive function, which is logic, reasoning, and decision-making, language abilities, both the ability to express yourself and understand what other people say to you, and visuospatial function, the ability to recognize faces, to recognize three-dimensional structures. We often see that people lose their ability to navigate or recognize landmarks that are well known to them. Most people have onset of Alzheimer's disease and related dementias after age 65, but there is a large group that has onset of their disease before then. And I don't blink an eye anymore diagnosing someone who's younger than me with the first symptoms of Alzheimer's disease. And we often forget that there is this group with early onset. And then there are also about 1% of people with Alzheimer's disease have a familial form of it, an autosomal dominant form, where over half of people in that family have will develop Alzheimer's disease because they have a flawed gene. For most people, Alzheimer's disease is a sporadic disease. It happens and we don't have a full understanding why. There are some genetic risk factors, lifestyle risk factors, but mostly it still remains a mystery. So the most common symptom of Alzheimer's disease is an insidious onset of forgetfulness, and it is progressive. And basically, it starts with short-term memory, and then later in the course of the disease can expand to long-term memory. And this is different than just the memory loss of aging. What I mean by that is that starting in midlife, everyone basically starts to have some changes in their memory. Because when I say this, short-term memory loss, a lot of people go, "Oh my God, I'm experiencing that." So this is different. It is, dense. It's problematic. It's progressive. It's not the retrieval issue that is associated with normal aging, where somebody, knows they know the information but cannot retrieve it from wherever it's stored at that moment, but it often comes to them a couple of minutes later. It's not the problem that you see when people have difficulty because they're multitasking, and that also tends to kind of not work as well as you get older. But insidious onset of short-term memory difficulties that are very persistent, observable by other people, and progressive is the most common initial symptom. Then, language abilities, especially the ability to express yourself, find the right words, and executive dysfunction, the inability to kind of reason, to make good decisions for yourself. So logic, reasoning, the ability to kind of take a problem, break it down into manageable components, solve each component, and transition kind of through it in an orderly fashion until you have the problem resolved. That's often an early symptom of Alzheimer's disease as well. So the problem with Alzheimer's disease, I'm just going to ask you, somebody opened up my door and I want to close it so that there isn't any noise pollution in here. Sorry about this. So Alzheimer's disease isn't a condition that you wake up with one day. It's not like a stroke where something happens and basically you're afflicted immediately. It is an insidious disease that takes really decades to take full hold. We actually know that the initial changes in the brain probably happen about maybe 20, 30 years before any clinical symptoms emerge. So what I mean by that is that you're going to get Alzheimer's disease, clinical Alzheimer's disease at age 70, those changes, the plaques and tangles that I mentioned before, have started to form when you're 50. Maybe even a little bit before that. So this is a dimensional disease, and actually the clinical expression of this disease is a late stage in the whole disease process. By the time you have clinical symptoms, we believe that about 50% of your brain cells are either killed or significantly impaired. So now you begin to understand that maybe there are some things that are not necessarily directly causative, but can kind of either accelerate or slow this kind of process, this evolution of the disease, and why it is so important to try to kind of correct this to the best of our ability, so that we can, even if we have Alzheimer's disease changes in our brains, that we can live our life without symptoms, without impairment, maybe for another 5 years. There's a big difference if you were to develop Alzheimer's disease at age 80 or 85. That simply is is a fact. You have 5 more years of quality, because this is a horrible disease. It's a disabling disease. There's no silver lining. There's nothing that you see with Alzheimer's disease that you kind of can say, oh, there's a redeeming quality here. It's a relentless disease that robs you of who you are, your individuality, robs you of your independence, and you become totally dependent on someone else, most often your spouse, who also is elderly, and certainly not the golden years that any one of us hoped for. The first changes in the brain that we can pick up is actually this buildup of this toxic protein, A beta 42 or beta amyloid 42 amino acid fragment. And that is something that we're beginning to be able to identify in kind of clinical research very early. And we hope to kind of develop treatments that will really help us kind of bend the curve in a very meaningful way that goes actually above and beyond what we can do with kind of lifestyle changes and diet changes and things like that. So the main point that I wanted to introduce to everyone is that only 20, 30 years ago, let's 30 years ago, we kind of just defined Alzheimer's disease as something that kind of emerged. You had this meaningful impairment, and now you had Alzheimer's disease. But in the past 30 years, we've kind of defined the condition as a dimensional condition that has a preclinical stage, which is long, actually the longest stage of the disease, where you have no clinical symptoms. It's just silently taking hold in the background. Then we have a period of very mild symptoms that we often refer to as mild cognitive impairment or mild behavioral impairment. And, people are kind of, is this normal? Is this abnormal? What's going on? Those that are most kind of cognizant of their own changes begin to kind of bring this up. And I would say about 30% of the new patients that we see in our specialized memory disorder clinic have this mild cognitive impairment stage, very mild. People struggle a bit more with, managing their affairs independently, but they still can. The clinical stage, you really develop a disability. It's a disease stage where you no longer can kind of, manage your affairs independently, and you become more and more dependent on others. So Susan covered this very, very well, that hearing loss can have an impact on dementia and your risk of developing dementia. And I think that it's important to understand that, I don't think that hearing loss causes the changes in the brain and somehow initiates Alzheimer's disease or other dementias. But the brain is a trophic organ. What I mean by that is you have to use it. It has to be active. It has to communicate. And what can happen with hearing loss is that people get isolated, they withdraw, they don't engage in cognitive activities in the same way. And we now have significant research showing that that hearing loss, mild loss, moderate loss, and severe loss, that there's a kind of an escalation in the negative impact on the kind of emergence of the clinical stage of Alzheimer's disease. So basically, we have significant data, case series, and other observations that show that hearing loss, and especially untreated hearing loss, is strongly and independently associated with likelihood of having dementia. It's not just a kind of a co-traveler, or that there's a condition that somehow is domineering and causes both. So we believe that that age-related hearing impairment contributes to your dementia risk, and that longitudinal observational studies of older adults suggest a 30 to 40% accelerated rate of cognitive decline, and with a substantially increased risk of kind of converting to clinical form of dementia. So the reason I spent so much time on kind of saying that this is a long process and that there's a chance to bend the curve is that I don't want someone to come away with thinking that hearing loss is causative and cannot be managed or rectified, and that basically it's part of these things that seem to accelerate the decline and cause dementia to emerge earlier than it otherwise would. So we think that it contributes to overall poorer cognitive functioning through the effect of hearing impairment on your cognitive load, on your brain structure, on decreased social engagement. There's actually a novel intervention that is being done right now where they flicker light and sound at a certain rhythm, and that this can amplify the normal communication electrical rhythm in the brain. And, so this is a new and fascinating kind of aspect of maybe yet one additional wrinkle to how dementia comes about, and how vision loss and hearing loss could contribute or increase your kind of risk of earlier onset. And that the conclusion is very clearly that the benefits of early screening for hearing loss and management of hearing loss are likely significant in terms of at least removing this accelerant, and also without risk. We know that hearing loss is associated with increased risk of depression and anxiety, for example, in late life, and managing hearing loss and minimizing its impact has broad-based health benefits. Because of kind of where I think hearing loss has the kind of this accelerant impact, I want to talk about prevention. And prevention when it comes to dementia, such as Alzheimer's disease, is a relatively new conversation, but it has kind of led to a kind of a rapid pace of discovery. And why would we think about prevention? Remember, I said that by the time that you have clinical onset of Alzheimer's disease, about 50% of your brain cells are either significantly impaired or dead. By that time, you already have a brain that is fully saturated with the toxic beta amyloid that has formed all of those plaques all over the brain. And you're starting to see a significant amount of tau tangles that break down the transportation infrastructure within these big cells. Neurons are the biggest cells in the human body. So why prevention? Because the damage is already so great. If you just act once you have clinical symptoms, current treatments are very inadequate. We have now considerable data on risk markers, what increases your risk of developing Alzheimer's disease. We have ability to recognize sub-disorders, or what, the mild cognitive impairment or very earliest clinical symptoms before you lose any functional abilities. And more recently, the revolution in Alzheimer's disease and dementia, especially in the research end, but will soon be in the clinic, are what we call biomarkers. We can now, through very sensitive analysis, measure the earliest changes in beta amyloid and tau, and markers that suggest that brain cells are dying off at an accelerated rate. So we can identify these changes even in people that have no clinical symptoms whatsoever. So we don't want to only look at the tip of the iceberg. We want to see what's underneath the surface. So dementia is a major contributor to late life disability and misery. About 13% of people older than 65 have dementia. Another 10 to 15% have mild cognitive impairment. So that's a substantial number as well. It is driven by age. At age 85, somewhere between 32 to 48% of individuals will have evidence of a dementia process. It's a relentless progressive disease, like I said before, that creates very significant disability and misery, and affects not just the patient, but the caregivers, the family as well, because very quickly in this disease you lose independence. You have to have someone who supervises you and make sure that things are safe. Treatments are lacking, and even the treatments that are available are not sufficiently accessed. And the workforce is not there to manage dementia well, anything but. So we think that protecting intact neurons will be more feasible than repairing the damaged neurons. We think that maybe we can modify some of the genetic risk factors. For example, if you carry a gene called ApoE4, so ApoE4, or the E4 version of ApoE, it accelerates your age of onset. So maybe we can go in and genetically modify the flawed genes to decrease your lifetime risk. So right now, just like with hearing loss, basically bringing in tools such as hearing aids or the other aids that kind of minimize the impairment. There are things that we can do in terms of dementia to minimize risk. So healthy lifestyle changes, dietary changes have a very low downside risk, are not dangerous, while we kind of bring about. And even once we have effective treatment interventions. Like with any other disease, we should think about what is it that we can change. Because timing is everything. You want to be able to, right now, we can only basically act on this very kind of small part of the dementia process. Once you have dementia symptoms, we're beginning to move towards MCI, but we really want to move much earlier so that if we're able to bend the curve, that it becomes more meaningful over time. So we know now that we can identify through measuring proteins in blood, in cerebrospinal fluid, or through very complex PET scanning. We can identify changes, like I said, maybe up to 15, 20 years before any clinical onset. So if you have high cholesterol and high blood pressure right now, you're likely to have no clinical symptoms whatsoever. But those two conditions are kind of wreaking havoc on your on your vascular health. And so 20 years later, the strokes and the heart attacks may happen. And we don't think that that's really appropriate, that you only react once you've had a stroke or had a heart attack or even two. No, right now we treat early to lower the bad cholesterol and to lower your blood pressure. And that's just a standard expectation. Anything less is an opportunity missed. And the same will apply to dementia and Alzheimer's disease in the not too distant future. We know, for example, that if you have elevated amyloid burden, that your course in terms of loss of cognitive abilities is accelerated. And this is a study from Australia that actually shows that that patients that either were cognitively normal or had mild cognitive impairment, that if they were amyloid positive, so the orange and the yellow line, they declined over 3 years, much more noticeably than those that were not amyloid positive. So we know that we can identify those risk factors. We can measure the bad beta amyloid either in cerebrospinal fluid or on specialized imaging scans. Here you have basically an MRI, which doesn't really show much. What you will see here is that a normal brain, you can look at the hippocampus. That's the seat of short-term memory. And you see that once you have Alzheimer's disease, that area in particular has kind of shrunk, shown atrophy. But that's a tough call. So we've come up with PET scans where we can inject a ligand intravenously and then take a gamma camera picture, and we see basically the ligand that has low-grade radioactivity bind to parts of the brain. The red and yellow is basically shows binding, and blue is basically no binding. So cooler colors, no binding. And you see that someone with Alzheimer's disease, basically their brain is lit up because there are amyloid plaques all over the brain. Here in the middle, you see a tau PET scan that shows that, especially again in the hippocampal region, you begin to see an increasing tau tangle burden. And this is one of the reasons. That's an area that is particularly vulnerable to the toxic effects of Alzheimer's pathology. And that's why short-term memory loss is such an early symptom of Alzheimer's disease. You cannot make new memory when your hippocampus is significantly damaged. So there are PET scanners all over. You know, at Strong, we have only 2 of them. And they're used a lot in oncology for metastases and cancers. So that's an expensive proposition to do a lot of PET scans for Alzheimer's disease, because this disease is so common. We have 6.5 million individuals in the U.S. right now with clinical Alzheimer's disease, and at least 2 or 3 times that have preclinical or prodromal conditions. So most people in America are not very happy about getting a spinal tap, or what we call lumbar puncture. That has a very bad rap out there. So we are moving towards blood-based biomarkers where we can measure it. We now have technology that allows us to measure these minuscule changes in these proteins that signal that you're at higher risk or confirm that you have Alzheimer's disease. And the beauty of that is that, we're all used to having our blood drawn. The procedure, the venipuncture, is relatively inexpensive. The analysis is less expensive, and the equipment. You don't need specialized equipment to draw blood. You don't need to have this complex PET scanner machine or the equipment to be able to do cerebrospinal fluid testing. So blood biomarkers have seen an incredible kind of progress in the past 5 to 10 years. And I think within 5 years, we will see these widely in the clinical setting. So that will allow us for large-scale screening in the not too distant future. And as we establish disease-modifying therapies for Alzheimer's disease, not just treatments that deal with the consequences of the disease process, but actually target the flawed beta amyloid or the flawed tau, that will then allow us to truly kind of bend the curve. And we've started those clinical studies already, and it's exciting to see where we're going with that, actually. Wouldn't it be amazing if we can just screen for Alzheimer's disease, and long before you have any symptoms, maybe put you on treatment that hopefully would prevent you from getting this disease, during your lifetime. But the treatments have to start early. They probably have to start at the preclinical stage when people have no symptoms, because the damage is just so significant in those later stages. And we've been doing these trials. The A4 study we've been doing that for 5 years now, using an amyloid suppressing agent versus placebo, and we'll have the top line results probably end of this year, or early next year, not end of this year. We will complete the study this year. Regrettably, we won't have the results until probably like February, March of next year. But that could really show us if we can truly bend the curve. This is one of the early humanized antibodies targeting beta amyloid, and we've since really amplified these antibodies, and the ones we're working with right now are much more robust. So we just started a year ago another study called A345, where we take people that are cognitively normal and either have very minimal increase in beta amyloid or clearly increased beta amyloid, and we treat them with a humanized monoclonal antibody for 4 to 5 years. And about half of the participants, are randomized to a comparison group that receives placebo. And we're just about to start a new study that has the moniker Skyline. Also, people with normal cognition that have elevated beta amyloid on first a blood test and then confirmed on a PET scan. So I said that there were some modifiable risk factors that we can, look at, and I think that is something that many of these risk factors, like I said, are something that we can do something about. So low education, and by that I don't just mean you didn't go to school for long, but that you really were not a lifelong learner, that you just kind of stopped early on. And since that time, you really haven't tried to expand your horizon. That is, my perception of low education, because I know a lot of people that just didn't have the opportunity to go far in school, but then in adulthood kind of used all kinds of options to basically expand their educational level. But that's a strong modifiable risk factor. Smoking, another modifiable risk factor. Physical inactivity, depression, untreated depression, midlife hypertension, that is untreated, diabetes mellitus, midlife obesity. A lot of these things go together. Midlife obesity leads to adult onset diabetes, often associated with hypertension. And this comes about because there is physical inactivity. Other things would be hearing loss, possible protective factors, physical aerobic exercise, but a combination of aerobic exercise and resistance training is best. Dietary antioxidants, and that does not mean that you can just take supplements. It is really focusing on improving your diet. Low-fat diet, heart-friendly diets are protective. Very modest alcohol use. And this has become more and more questionable. And people often ask me, so what's modest alcohol use? It's about 1 drink a day. And it's not like rollover minutes where you can say, I didn't drink Monday, Tuesday, Wednesday, Thursday, and therefore I can have 5 drinks on Friday. Then alcohol becomes toxic. And if you have kind of episodic heavy drinking or more consistent heavy drinking, you will actually see accelerated brain atrophy. Cognitive engagement, for example, participating in an organization like the HLA, conversing with friends, staying active, critical thinking, good sleep. While you're asleep, the brain takes out the trash, so that matters. They flush out the bad proteins. We are born with a certain degree of cognitive reserve, and we can increase our cognitive reserve. And the gradual decline in mental capacity across the human lifespan is neither subtle nor trivial. And if we're lucky, we use our lifetime to build our cognitive reserve, because the greater our cognitive reserve, the greater our ability to withstand the inevitable challenges of aging. You cannot avoid aging. We can modify aging, but we cannot avoid it. there are people that end up having a brain autopsy that actually have pretty advanced Alzheimer's changes, surprisingly advanced Alzheimer's changes, but they had no clinical symptoms whatsoever. They appeared to be able to kind of run on fumes, but somehow they had a very efficient cognitive reserve. So, brain fitness strategies. Well, certain medications, if you treat your blood pressure, if you treat your high cholesterol, if you treat your depression, those can make a difference. We hope to have medications in the future that will deal with the beta amyloid and the tau and the neuroinflammation and the oxidative stress in the brain. Reduce your stress. Stress is toxic. It is brain toxic in particular. Stress hormones are toxic. You can increase your physical activity. You can improve your diet. You can increase your mental activity. Some helpful habits, you want to socialize, you want to exercise, you want to engage, maybe find a partner in crime, to walk and talk. Vary your routine. Just don't always do the same thing. Be a lifelong learner and train your brain. Again, I mentioned stress, de-stress, figure out ways to kind of, deal better with stress or simplify things so that stress isn't as prevalent. Try to enhance your sleep, get good sleep. Be creative. Again, socialize, eat right, watch your numbers. By that, I mean, your hemoglobin A1C and your fasting glucose, your cholesterol, and especially your bad cholesterol, your blood pressure, etc. Be mindful of those things. So that was my last slide. I know that I've spent about 50 plus minutes, but I wanted to leave a little bit of time if if, for example, we can use the chat function if people have some let me see. Okay, go ahead. I see a hand up, so.
Yeah, Charlie, before we start the questions, Charlie, are you able to delete the screen on the one side so that we can see everybody?
I will try to unshare.
Yeah.
Unshare. Great, thank you. Okay, the first one who has her hand up on our screen is Cindy Kellner. So Cindy from Florida, would you please unmute yourself? Now, Cindy, you're still muted.
Okay, can you hear me now?
I can hear you now.
Great, thank you. First, I really appreciate your presentation, Doctor. I lost my father to Alzheimer's 17 years ago, and it's horrible.
Yeah.
But my question, and I really appreciate you making this forefront of your practice. It's important. But I have an observation, not as much as a question. Nursing homes and hospitals need to be more informed and better trained, in my opinion, to treat hearing aids much like they do glasses. My mom was in and out of nursing homes, emergency hospitals, rehab the last 3 months, and she wears 2 hearing aids. Consistently, I would go up there to see her and they weren't in. And I spoke often to the nurse about it, but particularly when you're under a stress in a hospital stay, I think it's so important that the staff make sure you have your hearing aids just like they do your glasses. And I think it's, incumbent on all of us to educate when we go up there and say, hey, look, this is really, really important. Because my observation is that they don't often put them in. They just, they're busy, and I get that. But to me, I'm lost without my hearing aid, totally lost.
Yeah, Cindy, I could not agree more with you. Regrettably, I think that we have not kind of age optimized healthcare, and it's shocking because who are the biggest consumers of healthcare? Older individuals, and we just don't
Exactly.
do well. So it's disappointing that we have a business that doesn't do better by their best customers. If we just think about it from that perspective, from a business perspective, it should be obvious. From a healthcare perspective, this should be obvious. But it is lacking, and I would think that hearing aids might be even more important than glasses, because everything is communicated to you verbally, and there's so much going on. And if you just don't hear what's going on, it's nobody's it's to nobody's benefit. People are very busy, and they get kind of cranky if they can't be very efficient and you can't cooperate. So a very good point.
Thank you. We have 3 minutes,
Thank
2
you.
minutes left. We have 3 minutes left. So
Go ahead.
quick questions, Eric.
Yeah, I'm sure I speak for a lot of us, but I'll speak for myself. I wear hearing aids, and that helps to boost the volume, but I still need people to speak slowly and clearly, and I want to thank you, Doug, for doing that. But I think amplitude is only half of the issue. The other half is the ability to process what we hear.
Yeah.
And when that becomes really marked, is it something we should have checked?
Yeah, I mean, I think so. If basically one of the things you see with hearing loss is that you try to kind of when I see people, then I evaluate for a cognitive impairment and there is hearing loss. I try to isolate out what is directly due to the hearing loss and what has changed to a point where now they don't seem to remember. And can we make sure that it isn't because they didn't hear, or that they're processing information in a, that is very different. They're reaching conclusions that, where the rest of the family is going, how on earth did they come to that conclusion? Why did they make this decision? Why did they become so vulnerable to that scam or whatever, and what's going on? So, dementia is highly related to brain processing. And if you notice that your brain processing is impaired above and beyond what you think is, for example, related to limited input, that might be a time to get an evaluation. Susan, next one.
Well, we have less than 1 minute, and I want to make sure you are thanked so much for your presentation, Dr. Porteinsson. It was absolutely wonderful. It was informative. It was inspirational. I think we're all going to get out and run around the block. We're going to make sure we get a good night's sleep. And it was just wonderful. And you're so kind to take your time and to prepare this presentation. And we are most grateful. And I also want to commend our captioner. I found myself watching Joe Gale do the captioning, and all of those long words that you were saying, she got every one.
Oh my.
So I do hope that the YouTube presentation or whatever it is includes the captioning, because it was just perfect. So Art, do you want to say it's now 1 o'clock, and
No.
What would you like to do?
Well, I want to thank the doctor for coming and this really good presentation. I want to remind folks that we do have a healthcare task force where we're trying to figure out ways to make things communication better between the patient and the medical staff. particularly in the hospitals. That's very hard to do, but we're probing at that, and we want to keep going on that. Pardon me, my voice. Also, don't forget to fill out your evaluation forms, because we will be planning the coming year, and we certainly want to know. To me, a lot of it's content. We got to have good content. What are you really interested in having? Answer the evaluation questions, but if you have other ideas, put those down too. And thanks to Charlie and the captioner for excellent jobs today. These things are moving along. I think we're getting a little better at it. But next month we'll try to do a hybrid and see how that goes, and that'll be fun. So take care, and thank you all for coming. We really appreciate it.
Thanks, everyone.